and we're going to invite Rene Almeling to come to the podium. Do you have slides? Okay. So Rene is an assistant professor of sociology at Yale, where her research interests are in gender and medicine. Among her very interesting and relevant research is a survey related to women's experience in IVF. So, welcome and thank you.
Okay. So today I'm going to be discussing the policy analog of IVF with a focus on egg donation, and my remarks are going to center around what I see as three of the main issues when it comes to social and ethical policy considerations: kinship, risk to egg donors, and commodification. So in contrast to the UK and many other countries, the United States has exhibited a laissez-faire approach to regulating reproductive technologies, such as IVF and gamete donation. The FDA requires that egg and sperm donors undergo some forms of testing for contagious disease, but beyond that, there are no federal rules about who is allowed to donate, how often they're allowed to donate, and how much money they can be paid. So the American Society for Reproductive Medicine does issue guidelines on some of these issues on a regular basis, but those guidelines do not carry any enforcement mechanisms. So for the most part, the market for reproductive technologies and reproductive services, like gametes and surrogacy, have been left on its own and is only occasionally constrained by pushback from consumers or public opinion, as we saw with the case of Octomom, or recent controversies around sperm donors who find out they have 50 or 100 offspring. So in my mind, one of the major questions facing the panel is whether American federal agencies will continue this hands-off approach with MRT, or whether there will be a more concerted effort to legislate and regulate. So in making that decision, one of the major issues to consider is the extent to which women donating eggs for mitochondrial DNA will be considered by themselves or by others to be parents. Several people have raised this issue of kinship. I'm going to talk about it from the perspective of some empirical research that I did with egg donors in the mid-2000s. So in the press and here today, many people have referred to this technique as three-parent embryos. But my research suggests that present-day egg donors who donate all of the DNA, nuclear and mitochondrial, do not perceive themselves as mothers. So I'm drawing here from a chapter in my book, and I'll talk a little bit about egg donors and sperm donors to provide the contrast here. So gamete donors are similar in that both men and women who donate their eggs or sperm are each providing half of the genetic material you need to conceive an embryo. But in my interviews with them, they had very different views of this genetic and biological relationship. Sperm donors had a straightforward view of themselves as fathers to those offspring, while egg donors were adamant that they were not mothers. So if you would click to the next, or I don't know if I can do it here, yeah. Sorry to any flashbacks to the SAT that this provokes in those of you. So sperm is to father as egg is to not mother for gamete donors. Women donating in different programs, different parts of the country, all use the same phrase. All they were donating was just an egg, to distance themselves from the idea that they were mothers giving up a child. So here is what reproduction looks like to an egg donor. All they give is just an egg. There's a question mark to represent uncertainty. That egg may or may not fertilize. It may or may not result in a pregnancy. The pregnancy may or may not miscarry. Somebody else is gestating the pregnancy. Somebody else is giving birth. Somebody else is rearing the child. Right? So egg donors say all they do is just this first part. It's just an egg. They're not mothers. Interestingly, surrogates do the same thing. All they do is just the pregnancy. They're not providing the egg. They're not raising the child. In contrast, this is what reproduction looks like to a sperm donor. Yeah. He provides the sperm, there's definitely a baby, and he is the father of that child. So this goes to show, I think, how our cultural definitions of motherhood and motherhood are much more flexible than our definitions of fatherhood. So we still have a cultural equation in which providing sperm makes a man a father, whereas egg donors can sort of flexibly decide whether or not they're going to consider themselves a mother. Okay. So this distinction that some people have referenced between biological and social parenthood is actually a gendered distinction. And that's important when we start thinking about mitochondrial DNA donors, because I think if a traditional egg donor does not perceive herself as a mother, then it is very unlikely that a woman who is just donating the mitochondrial DNA is going to think of herself as a mother. The question is whether or not the recipients and the offspring of those mitochondrial DNA donors will think of the mitochondrial DNA donor as a mother. And I think that really comes down to a question of what those 37 genes on the mitochondrial DNA convey, right? If there's nothing that a child can point to and say, oh, well, I get this from my mitochondrial DNA donor, then I really question as to whether or not that genetic material will be seen as powerfully meaningful, or it's going to loom very large in the psychological landscape of recipients and offspring. So in other words, as somebody mentioned earlier today, there's certainly 3 people involved in the creation of these embryos, but I think it's an open question as to whether parties involved will actually see those 3 people as parents. As my data suggest, there's no easy biologically determined relationship between the provision of DNA and how people think about it in terms of kinship. Sperm donors provide DNA and think of themselves as parents. Egg donors provide DNA and do not. So even though I'm speculating that the recipients of MRT and their children are unlikely to think of the mitochondrial donor as a mother, they might. And for this, I'm just going to point to this comment about IVF. You know, when IVF was new, people thought of this as very unnatural, test tube babies, but it's become extremely normalized. And in part, I think it's because the same woman is involved in every stage of reproduction. The same woman is providing the egg, gestating the pregnancy, giving birth, and rearing the child. So that's one way that IVF became normalized, whereas egg donation and sperm donation still are not normalized in quite the same way because additional parties come in at different points. And so a mitochondrial DNA donor will be an additional party. So this is where I think there's an open question as to whether or not that mitochondrial donor will be seen as a parent or perhaps not. Cultural meanings are hard to predict, but they can influence not only family dynamics among those who use technologies like this, but also public opinion about the acceptability of such technologies. So this is one of those issues that if a clinical trial did go forward, I would want to see an interview study with women donating mitochondrial DNA and the recipients and the offspring as to the meaning that they assigned to that mitochondrial DNA. Now, the second 2 issues that I'm going to just touch a little more briefly on, risk and commodification, are both already very well known from the realm of egg donation. And in contrast to what Hugh Whittle mentioned before, which is that they're not unique to MRT, but I don't think this is grounds for dismissing them. I think, in fact, the risk to egg donors and the commodification of egg donors are important contextual factors that the committee needs to weigh in terms of going forward. They're not things to just sort of push aside because they're not unique to MRT. So first, the risk to egg donors. This is a category of risk that is often overlooked in scientific articles published about the safety of MRT. People talk about the risks to the recipients, the risk to children, the risk to future generations, but the risks to egg donors are often ignored. So I was very happy to see it on Jeff's slides in the introduction this morning, but you actually only had 1 bullet point, ovarian hyperstimulation syndrome, and that's a short-term risk. So I would add another bullet point to the risk to the egg donors of the unknown long-term health effects of undergoing ovarian stimulation. So mitochondrial DNA donors will also undergo ovarian stimulation and egg retrieval, and those women will face all of the risks, known and unknown, that women who undergo these procedures face, whether they're producing eggs for their own IVF treatment, donating those eggs to an anonymous stranger in exchange for money, or freezing eggs for their own future fertility treatment. The problem here is that we actually have very little data on the risks associated with hormonal stimulation over the long term. Even these short-term risks, the ASRM estimates that in 1 or 2% of cases, the risk to women from ovarian stimulation will be serious enough to land them in the hospital. Those are not based on empirical studies. That is an estimate that is derived from studies that are of 1 or 2 clinics that have shown up in the literature. And that's only the short-term risk. So I think this is really important. In the 35 plus years since we've had IVF, there have been 0 longitudinal studies done to evaluate the long-term effects of exposing women's bodies to fertility medications. There have been a few retrospective studies that have appeared in recent years, but this gold standard of following women over time to assess the risks have not occurred. So actually, in providing women information about the risks that they're undertaking, we don't have information to give them about the long-term risks. So again, a known issue with IVF and egg donation, and it would extend to women donating eggs for MRT. And then finally, on the issue of commodification. If women who are donating eggs for mitochondrial DNA will be paid, just like traditional egg donors donating for fertility treatments, they're going to be wading into a decades-long debate about commodifying reproductive bodies. Or we could follow the path of stem cell research and not pay them, in which case we would find that we have very few women willing to be donors, because in the American market, women can earn quite a lot of money for their eggs. And this is related to another problem that a number of speakers have mentioned already, so I will just underscore it. These long-standing issues with the market-based American healthcare system, inequality of access to healthcare, and medical technologies of all sorts. So these are important pieces of the larger picture that deserve to be addressed when we ask who exactly will be able to use these technologies in the effort to prevent diseases in their children. Thank you very much.
Thank you.